It's my first one, so I'm a little confused. But so welcome everybody to our first ASF webinar. And what we're going to talk about today, some of you may have seen me talk at some of the family meetings, and I've only really talked about seizures, but today I'm going to talk a little bit about seizures again, and then also treatments for seizures, including newer medications and dietary therapy, which I haven't really talked about at the meetings before. So just a real quick couple slides of intro. Angelman syndrome was first described in 1965 in 3 children by Harry Angelman, and he originally called it happy puppet syndrome. That was the name of his paper, but later on it was renamed after Dr. Angelman himself. About 80 to 90% of people will have seizures, and nearly 100% have abnormal EEGs. So the causative gene in Angelman is the UBE3A gene on chromosome 15, and it was discovered in the 90s by Dr. Wagstaff and Dr. Baudet. I won't get into the biology of UBE3A, but the bottom line is how we know a lot about the basic science, and we know a lot about the clinical aspects of Angelman syndrome, but how you get from point A to point B is still not really well understood, and that's kind of where a lot of the research is focused right now, is how does that single gene not working kind of create everything that we see in people with Angelman syndrome. Also, next to the UBE3A gene is a cluster of genes that code for GABA receptors, and what GABA is, it's the main inhibitory chemical in the brain, and so what GABA does for most people is kind of quiets things down, and one of the things it does is kind of quiet seizures down. But when that's not functioning right, then so we think that those GABA genes also lead to part of what we see with the seizures. And the prevalence is listed as 1 in 10,000 to 1 in 20,000, but as newer tests come out, as the technology gets better, the prevalence really seems to be closer to 1 in 10,000 people have Angelman syndrome. So here's just a kind of a picture of the 15th chromosome. You can see BP2 here and BP3 here. That stands for breakpoint. That's just kind of where the chromosome can kind of break off in certain spots. And the UBE3A gene is right here, kind of in the middle of all of it. And but then the GABA receptor genes are right next to it. So that one single gene we think is kind of the main gene causing everything, but the genes around it also are playing some role. And so if you look at the next slide, so here's chromosome 15. This is what we call the critical region that I just showed the bigger view of, with UBE3A kind of right in the middle of it. So those that have maternal deletions, which is about 70%, so basically people that are missing that chunk of their mother's chromosome right here, have Angelman syndrome, and those people tend to have the most severe problems, so the toughest seizures to control, the most problems of development, the worst sleep, all that kind of stuff. And we think that's because not only is the UBE3A gene missing, but also the GABA receptor genes are missing, and plus all those other genes are missing. Whereas those that have a UBE3A mutation, so the chromosome's totally intact, but the gene itself just isn't working right, which is about 12% of people with Angelman syndrome. Those kids tend to have easier to control seizures, more communication, more actual speech, fewer sleep issues. It's still kind of all the same issues, but just really a milder version. And then what imprinting center defects are, and that's about 2 to 3% of people with Angelman syndrome. Basically, that's when you have 2 functioning chromosomes, but the imprinting center, which turns the moms off and turns the moms on and the dads off, the imprinting center, which turns that gene on, just isn't working right. So the gene is fully intact, but and as it should be, but just never gets turned on. And those kids tend to have the mildest symptoms of all. And then uniparental disomy is when you get 2 copies of the dad's chromosome. So they're 2 kind of healthy functioning chromosomes, so they both came from the father, so neither one gets turned on. And then when you look at seizures, this is from the study we did back in, I think we did it in 2007, published it in 2009. Those with deletions, about 90% have seizures at some point. The unknowns, it's also around 90%, but we think that most of the unknowns were older parents that didn't know the specific mutation, because when kids were tested, 10, 20 years ago, or 10, 20 years ago, they didn't have imprinting center UBE3A, so those weren't really discovered yet. So we think a lot of those unknowns were actually probably people with deletions. And then when you look at the UPD and the UBE3A, only about 75% of those people will have seizures at some point. And then with the imprinting center folks, only about half will have seizures. So really, the type of mutation you have really depends on how frequent and how severe the seizures will be. And that's not to say that you can't have a deletion and very mild seizures, or UBE3A and have difficult seizures, but in general, those with deletions have more frequent, more severe seizures than the others. So as far as seizure types, there's all sorts of different words, and there's words that used to be used and now aren't anymore, and then there's new words, and so it gets real confusing. So there's two types of seizures that we talk about, focal and generalized. So focal seizures used to be called partial seizures, so partial is now focal, so if you're used to hearing partial seizures, we call them focal now, but it's all the same thing. And really what a focal seizure is a seizure that just comes from one part of the brain. So generalized seizures come from the whole brain at once, whereas focal seizures come from just one part, and they can spread, but they just start in one area. And these sometimes they call it, under the old system with partial, they call them simple partial and complex partial. So simple partial just means that you'll have some, arm movements, face movements, whatever it is, that you're totally awake and conscious, whereas complex means that there's some impairment of consciousness. So it doesn't have to be complete loss of consciousness, but at least some impairment. And then what we call secondarily generalized is when a seizure starts in one part of the brain and then spreads quickly to the rest of the brain. And then generalized seizure, like I said, is just is the whole brain at once. And just to kind of give you an idea of the EEG, so basically you can see here that, this is kind of the classic spike and wave. So if you hear spike and wave, that's what it looks like. And you can see in this EEG, the whole EEG is just filled with spike and wave. So it's not just one part of the brain, it's the whole brain. It's a little bit higher amplitude or taller in the front of the brain, but still the whole brain is kind of going at once. Whereas a focal seizure, and this may not be the greatest, but you can see this very abnormal chunk here. And you look, and it's a little bit here, so this is both left. The odd numbers left even as right, so you got the two left-sided brain chunks, you see all those kind of abnormal spikes. But you see on the right side, down here, that actually looks pretty good. So that's a seizure coming from just one half of the brain. And this actually isn't an Angelman EEG. This is, might actually didn't have any because we don't really see a lot of focal seizures. But that's kind of what a focal seizure looks like. So the seizures that we do see in kids with Angelman syndrome, kids and adults, it's basically what we see are generalized seizure types. So Angelman syndrome is, the epilepsy associated with it is a classic generalized epilepsy. So kind of this EEG is kind of what we see. And so the seizure types that come with it typically are generalized tonic-clonic, absence, atonic, myoclonic, and tonic, and I'll talk about all those kind of one by one. And then just to confuse everybody, about 1/3 of kids will also have focal seizures. So when you have kind of a generalized epilepsy, if the seizures are significant enough, you can mix in some focal seizures. I know it's confusing, but rarely do we ever see focal seizures by themselves with Angelman syndrome. They're usually part of kind of part of a bigger kind of mixed seizure type picture where kids have lots of different types. So generalized tonic-clonic is the one that people know as grand mal. That was kind of the older term for it, and it's the one that we all think of when we think of seizures. So kind of fall down, eyes roll back, drooling, shaking of all four extremities, really scary to watch, blue around the lips. And so tonic is the part where you're stiff, the clonic is the part where you're shaking. And then afterwards what we have is called a post-ictal. So ictal is just kind of a fancy word for seizures. So after these kind of seizures, people get confused, they get fatigued, and it really takes a while to kind of reset everything. Kind of one important thing about these, they're terrifying to watch, but really a seizure has to go 45, 60 minutes or maybe even an hour and a half before there's actually any brain damage done. So kind of a classic 5-minute, 10-minute, even a 20-minute seizure, you're not going to get any damage to the brain at all. So as scary as it is to watch, there's really no damage going on. And once the brain kind of resets and people wake back up and get back to their old selves, then there's really no more to it than that. And these are really common in Angelman syndrome. Over 40%, probably 50% of people with Angelman syndrome will have at least one generalized tonic-clonic seizure at some point. So atonic is one of the most common. So atonic just means loss of tone, so atonic. And basically the most common way that presents is a head drop. So it's kind of sitting there, all of a sudden, boom, the head just drops. And sometimes it can be severe, and kids can hit their heads on tables, or if they're standing up, they can kind of fall down. And then, but it can be more than just a head drop. It can be a whole body drop. Sometimes people will just kind of fall to the ground. And this is often one of the first kind of seizure types that we see in kids. So often it goes unrecognized because it looks something really subtle, just kind of look like kids just looking down. So that's one thing to really watch for in little kids is head drop, because often that's the very first type of seizure that we see in little ones. And again, really common. Over 40 to 50% of kids with Angelman will have atonic seizures. And then tonic seizures, less common. So we see these more in kids with kind of any kind of growth abnormalities in the brain. So the kids that we see with the opposite of Angelman syndrome, the 15q duplication, so an extra chunk of that 15th chromosome, they have these little dysplastic areas in the brain, and they get a lot of tonic seizures. But it's really pretty rare in Angelman syndrome. Probably less than 10% will have any tonic seizures, and that's really just whole body stiffening, but without the shaking. So tonic-clonic are the big grand mals. Tonic is just the stiffening part, so stiffening for 5-10 seconds usually, but again, pretty I don't say rare, but uncommon in Angelman syndrome. And then myoclonic seizures is another pretty common type. So very brief contraction of a muscle group, so just really a quick twitch. For instance, if you guys get bored listening to me and you kind of feel your head nodding down, it snaps back up. That's actually myoclonus. We all get it when we fall asleep. You know, we all see, you know, kids or spouses kind of laying there sleeping and they twitch, and that's totally normal. But these are kind of more intense versions of that, and while they're awake. So that's kind of what a myoclonic seizure looks like. And they can be provoked by startling, by loud noises, sometimes by flashing lights. Kind of with myoclonic seizures, those little twitches you see in sleep, that's just called sleep myoclonus, and that's totally normal. What I've seen in a lot of kids with Angelman syndrome is that that can be exaggerated, so they can twitch a lot more than other kids, and it's not seizure, it's just part of the normal sleep process. They're just a little bit twitchier than most kids. So if it's only during sleep, then we don't really worry about it. And then in our study, we only found about 15%, but I think it was just the way the questionnaire was. It was a little bit hard to kind of hard to do the categories, but really it's probably closer to 40%, just like the atonic and the tonic-clonic seizures. And then absence seizures. So there's two different kinds of absence. There's typical and then there's atypical. So the kind we see in Angelman syndrome is what we call an atypical absence, and the difference is that with the typical absence seizure, there's a complete loss of consciousness, and it's very brief, only a few seconds. Whereas with the atypical seizures, they can be longer. They can be several seconds, even up to a minute. And you may not lose full consciousness. You can, if you kind of call someone's name, you may be able to kind of look over a little bit, not really respond fully, but kind of let you know they're there and listening. And those are the kinds of absence seizures we see in Angelman syndrome. And really all it is it's the classic staring spell, which used to be called petit mal, but it's the fancy name is absence. And again, really common, at least 40% of people with Angelman syndrome. And the focal seizures, which, like I said, not by themselves, not common at all, but sometimes you can see them mixed in with other seizure types. And what that is just a seizure coming from just one part of the brain. So depending on what part of the brain it's coming from, you get different symptoms. Kind of the classic ones that we see are the frontal central ones. That's kind of the biggest part of the brain. So if it comes from the front of the brain, you might get shaking from, or shaking or stiffening of just one arm or one leg, or the right arm and the right leg. Then the left side's okay, or vice versa. Or you may get the head and the eyes over to one side, but you know, it's different from a classic absence where you're staring straight ahead. So that's kind of the easiest one to recognize. In kids that can really communicate better, some, you know, depending if it's in the temporal, they may say they feel scared or get a strange smell for no good reason. Sometimes it's in the way in the back of the brain where your visual area is. You may kind of see some strange things, but the ones that we do see in Angelman syndrome are more the frontal central types, where you just get kind of eyes to the right, head to the right, or just shaking of one arm or one leg, that kind of thing. And then this was from our study back from '09, and it just kind of shows the seizure types. So these big four here, the atonic, the generalized tonic-clonic, the absence, and these are actually the focal seizures. This is myoclonic, but again, I think that was just the way we worded the questionnaire, and that probably should be kind of up in this neighborhood somewhere. That's very common Angelman. And the other ones are very uncommon. So tonic is much less common, and then just plain focal motor without the alteration in consciousness. But I'll talk about those kinds of things later. And then so you know, there's a lot of confusion about like seizure types and epilepsy syndrome. So what an epilepsy syndrome is it's a collection of seizure types plus some other criteria that make a full syndrome. And there's a couple that might come up in terms of Angelman syndrome. One is called Wes Syndrome, which is actually really rare. To be honest, I've never seen it in a kid with Angelman, but I have read about it in papers and seen case reports. But these are infantile spasms, and the kids with the 15q duplication, so with the extra piece of the instead of having like 2 Angelman regions instead of none, you know, they have a lot of spasms, and that's because again they have that dysplasia. They have parts of the brain that don't develop right, which is not the case in Angelman syndrome. So what you see is our spasms. So what differentiates a spasm from a head drop is that instead of just the head kind of dropping down and kind of just losing tone and just falling, the head is really forced down, and the arms come up to meet it, and those occur in clusters. I think there are some case reports. I heard of one kid who has Angelman but also had a stroke, and that's why he had his spasms. But again, it's really rare. I honestly haven't seen it in all the kids we've seen. But just something kind of to think about. But again, it's in the first few months of life. If it's not going to happen by a year of age, you're probably not going to see it. But just to kind of say that it is possible, but again, very, very unlikely. And like I said, I haven't seen any in the whole time I've been doing this. And then the EEG is very abnormal. It's called a hypsarrhythmia, but again, I've never seen this in Angelman syndrome. But what we do see is what we call Lennox-Gastaut syndrome, and so Lennox-Gastaut is, and some people have it diagnosed, some people don't have it diagnosed. But what Lennox-Gastaut means is it's just there's 3 criteria to meet Lennox-Gastaut syndrome. One is intractable seizures of mixed type. So if you have multiple seizure types, the most common being the atonic, the tonic, and atypical absence, so 2 of the 3 which we see commonly in Angelman. You can also mix in myoclonic, tonic-clonic, or focal. So basically mixed seizure types, which some people with Angelman syndrome have, some don't. EEG findings of generalized slow spike and wave, and I'll show a sample of that later. But typically kids that do have seizures in Angelman syndrome will have that generalized slow spike and wave finding. And then also cognitive dysfunction, so which is pretty much universal in Angelman syndrome. So if you have those 3 things, you have Lennox-Gastaut syndrome. So kids with Angelman syndrome that have head drops and staring spells and the occasional tonic-clonic seizure, they probably have Lennox-Gastaut syndrome. A kid with Angelman syndrome who has only absent seizures and it's well controlled would not have Lennox-Gastaut syndrome. So some kids meet criteria, some don't, but really, whether you have the diagnosis, it doesn't really matter. It's just kind of another way of classifying things. But that's what Lennox-Gastaut means if that ever comes up, if somebody mentions it. All it is just a constellation of findings, which are cognitive dysfunction, a classic EEG finding, and then multiple seizure types. And it doesn't, if someone gives you the label or doesn't give you the label, it doesn't really change what's going to happen. It's just a way we kind of classify things sometimes. And then the other one, which is actually really rare, is called myoclonic status and non-progressive encephalopathy. It's a really long name that should be kind of acronymed or something at some point to make it easier. But it's the newest of the epileptic encephalopathies that was described. And what the reason I bring it up is because there's only been there probably maybe like 50 cases worldwide where it's been reported in the literature. But the reason it's interesting is that about 40% had Angelman syndrome. So and honestly, I don't think I've ever seen this in a kid, but it's basically these really long episodes of myoclonus in early childhood. They typically cause developmental regression. So your young kids, usually age 2, 3, 4, probably like in the neighborhood of like 2 to 5, long episodes of just those twitches that you kind of see in sleep, but you see them awake, and just really sustained myoclonus with developmental regression. And so that's myoclonic status, non-progressive encephalopathies, but again, very rare. And honestly, I haven't seen it yet, but I mention it because 2/5 of those that have ever been reported have had Angelman syndrome. And then so moving on to status epilepticus. So actually, when you think of status epilepticus, you typically think of convulsive status epilepticus. So that's when you're having either having a generalized seizure, or it could even be an absent seizure, but having a clear clinical seizure that just goes on and doesn't stop. And so the kind of the classic definition is 15 minutes. There's different ones. Some definitions are 30, some say 5, but we typically go with 15. So more than 15 minutes of either one long sustained seizure or multiple seizures in between which you don't come back to your typical baseline. And again, this does happen in Angelman syndrome, and the most common times you'll see it is with fever or with poor sleep, or with a combination of fever and poor sleep. So it does happen, and that's why we have diastat. So the reason the rectal Valium, the reason that we say 5 minutes for the Valium is that most seizures stop in 2 to 3 minutes. So if it's going 5, you want to treat it, because if it goes 5, could it go 10, could it go 15? But there's no magic number for 5. It's just that it should have stopped by then. There's no brain damage at 5 minutes. There's nothing scary at 5 minutes. But we don't want it to get to that 45, 60, 90-minute range. So that's why we always say 5 minutes diastat, and then if it's not stopping, call 911. And then moving on to something that is very common in Angelman syndrome is non-convulsive status epilepticus. So this is something that really is really important, because it can be very significant, very scary, but it's also easily treated if recognized. So it's really important to recognize it if it happens So non-convulsive status is basically what happens is someone will just out of nowhere start having decreased alertness. You might see decreased eye contact, decreased communication, loss of balance, loss of appetite, just kind of just someone who's not having the skills they usually have, and for no good reason. They're not sick, they're not, there's no obvious reason. So just there's this kind of loss of their usual skills. And what's kind of tricky about it is that when it happens and the EEG gets bad like that, the brain really has trouble making actual seizures. So you may have kids that are having occasional absence or occasional head drops, and those actually get better, so you don't think, well, this is seizure. But really what happens is when the non-convulsive status is going on, the clinical seizures are often less. So you think, well, it can't be seizure. I haven't seen a head drop in a few days. But that's actually because the EEGs, because they're really seizing all the time, they can't make those kind of nice, kind of concrete, clear head drop type seizures. So, so really, Angelman syndrome is not progressive. It's not degenerative. Kids don't get worse. Kids don't go backwards. So when you see that, always think of non-convulsive status epilepticus. So any kind of loss of skills that lasts more than a couple of days, and you wouldn't want to do it after one day, because often when someone gets a virus, they'll look off for a day or two, and then you'll get the runny nose, the cough, the fever, and you say, okay, they're just sick. But if it's a few days and there's no clear reason for it, then we really want to get an EEG and kind of and treat, because if you treat it, well, I'll talk about treatment in a while, but really something that can be treated out of the hospital and effectively pretty quickly. And this is what the EEG looks like. So it's just spike, spike, spike. And this is actually a little bit with Angelman syndrome that came in after about a week of that, and just spike, 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 spike. So the whole EEG, and that's so. While doing this, he was walking and playing and eating and the whole bit, but just was not at all himself, and was just very off balance, and eye contact was terrible, and so this is what the EEG looks like. And so you can see, it's hard to make a seizure when you're kind of constantly spiking like that. So kind of getting back to the study that we did, that we published back in '09. That many of you may have taken part in. So we surveyed 461 people through the ASF, and found that about 60% have more than one seizure type. So for the 40% that don't have one seizure type, the Lennox-Gastaut will not apply to them. But a little more than half, can have 2 or more seizure types, with the majority being the generalized seizures. Now, in terms of age, so what we see is the most common time by far for seizures to start is around age 3, it's really uncanny how many little ones we see now, because before, the diagnosis wasn't made until kids were older, but now with microarrays and all these fancy genetic tests, kids are being diagnosed at 9 months, 12 months, so we get we get to see them early on and kind of follow them. But really that's really kind of the hot spot is 2.5, 3, 3.5. That's when most kids will start to have seizures if they're going to have them. And what we see is that the people with the worst seizures, the hardest to control seizures, it's usually in that preschool, early grade school kind of neighborhood, 3, 4, 5, 6, 7. That's when we struggle the most to get seizures under control. And then when puberty comes, most people tend to get better. And we see a lot of kids who had really, really tough seizures really improve nicely. We can actually get some kids off medicines. There's kind of that nice grace period. And then there's really not a lot of great adult data, but we did do a survey a few years back that's being submitted now for publication, where we talked to 110 families. Actually, Anna Larson herself talked to 110 families. And what we found, just kind of talking to all these families of adults with Angelman syndrome, is that about 2/3 of those who seizures improved at puberty, they stayed seizure-free or relatively seizure-free. So in most adults, the seizures go away and they stay away, but in about 1/3 they do come back, and in some people they can be tough to control again in adulthood. So the good news is that most adults tend to do much better, but unfortunately it's not all adults. There's still that chunk, that 1/3 that do have the seizures pop up, and there's a small subset of that 1/3 that they can be tough to treat again. So it's tough. I wish there was an age where you'd say, well, that's it, you're out of the woods. But really, once you get past, if you had that seizure stop at 12, 13, and they're stopped for several years, there's probably, as far as we know right now, about a 2 out of 3 chance that they're going to stay improved. But as more people with confirmed genetic diagnoses get older, and as time goes on and we see more adults, we'll have a better picture. But I think that's a pretty good estimation of what we see, is about 2/3 stay pretty well controlled, 1/3 don't. And this is kind of a little graph we have for age. So This is where the seizures started, and then it kind of got a little bit bigger. This is the 9 to 11, so it kind of, we saw the seizures get a little bit more frequent, and there's that little break in at puberty, which was nice. And so, okay, so this is something that we're looking at right now, and I can't even probably count how many phone calls, emails, questions we've had asked about it. But what we see in teenagers and adults, and we're actually working on a study right now, and hopefully we'll have that published soon, just so there's something to kind of talk about it. But we're seeing these episodes of sustained myoclonus, so just twitchy, jerking, but it can last for hours. And the youngest we've seen it is 10, 12, somewhere in that neighborhood. Where it starts, we've had several people start around that age, around puberty. Another subset start in their 20s. But what we see is these things will last for hours, and we've had some people that have had these 5-hour episodes, every day for weeks, and it's really scary, and it's really a big quality of life issue. But what we see, and this is not proven. This is my thought. I really think this is more part of the movement disorder of Angelman. So there's that ataxia, so the kind of the off balance part. There's the tremors that we see, and I think this later onset myoclonus is really more part of that as opposed to seizure, because there's really no post-ictal period when the event stops. They just kind of go right back to what they were doing. There's no regression of skills in between these things. People look great, and we've actually hooked a few people up to video EEG, and they're having these runs of tremor, and nobody that we've got an EEG on actually during an event has had any EEG correlate. So I really don't think these are seizures. I think this is part of the movement disorder, and so what we don't have a great idea of is how frequent it is, when it starts, how to fix it. I know that's kind of what we're working on, but this is probably the single thing that in all of treating Angelman syndrome, whether it's seizures, sleep, GI stuff, this is, I think, is kind of the least clear to me right now, and the thing that I have the most trouble fixing, because we don't really understand it that well. But I do think it's actually part of the movement disorder as opposed to the epilepsy. But since it's myoclonus, we use medicines that treat myoclonus, and I don't know if I have a slide for that later, but they're basically seizure medicines. So they're the benzos, clobazam, Klonopin, Keppra is good for those. Depakote actually does work for myoclonus, but it also worsens tremor, so I kind of avoid that. But again, these episodes are tricky, and we're actively looking at them. We're compiling data. We're trying to figure it out. But my real sense is that these are part of a movement disorder as opposed to epileptic. And then so the EEG, I'll just kind of go right to them. Pretty much almost every 96% of EEGs in people with Angelman syndrome are abnormal. And if we go back to here, this is what the seizure activity looks like. So kind of real tall spike wave. But then you look at kind of these things. So this is what we call frontal slow spike and wave. So it's not really that kind of classic spike wave. It's more these little spikes kind of buried in here and there amongst slowing. So this is kind of really classic for Angelman syndrome, but not really indicative of seizures. So if we get an EEG, just see a little bit of this, we don't worry that there's impending seizures. This is more just kind of part of the syndrome. And this is a really better example. So this is what we call the notch delta. So delta just means kind of really tall, slow activity. So you can see that's kind of higher than all the other bumps. These green lines are a second, so there's only 2 per second. So kind of slow, big, and they have these like bites taken out of them. So that's a little bit of sharp activity kind of mixed on top of it. But this, again, this is just kind of classic Angelman findings, but not what we think is epilepsy. And people have to be careful reading these EEGs, because we've seen, actually this one here, so this is, the classic is in the back of the brain, but I've seen a lot of EEG reports and people come to the clinic, and it said, frequent occipital seizures, over and over. But these aren't seizures. This is just kind of the classic notch delta and Angelman syndrome. So anytime, you get an EEG report and it says, frequent electrographic seizures, and the other kid that looks fantastic and is doing great, they're not seizures. There's these kind of typical Angelman changes. So it really, you have to be read by someone that really kind of understands how to read an Angelman EEG. So as far as treatments, what we found in the study we did was that about 77% of people didn't respond great to the first drug, and by not great means that you didn't get 90% or better seizure control with the first medicine. So about a quarter of people, you put them on one medicine, they do great, as opposed to kind of the general epilepsy population, or about half of people will respond well to the first medicine. Angelman syndrome was only about a quarter. And so these are the medications. So there's two different types of medicines. So there's what we call broad spectrum seizure medicines, and then there's ones that really just treat focal or tonic-clonic seizures. So when you're talking about a pure generalized epilepsy, which Angelman is, this list here, the focal, tonic-clonic, these are medicines to avoid. You do not want to use these because these can all exacerbate different seizure types like absence, head drops. All the seizures can get worse with these kind of medicines. You can put kids into status. When someone comes in convulsive status, so just kind of shaking, you can't stop, then phenobarbital, dilantin, those are fine to stop a big seizure, and those can definitely be used. But then you don't keep the kids on that because it can worsen the seizures afterwards. The one exception I will say to this is gabapentin. Gabapentin is really not that strong a seizure drug, so it doesn't really worsen. And honestly, I have some kids on gabapentin for sleep, but there's a difference between using a small dose for sleep and then a big dose for seizures. A big dose may even not worsen things that much, but I wouldn't want to risk it. So small doses for sleep or for migraines, I don't think will worsen, and the kids I've used it on, I haven't seen it worsen anything. But the rest, the phenobarbs, the dilantins, the tegratols, the trilactols, you really don't want to be on those for everyday use, and I would really avoid those. Whereas the other side of the list, the broad spectrum, these are all good for Angelman syndrome. The Zerontin or ethosuximide is only good for absence, so I only use that as an add-on. I don't like to use it as a single drug because it's only going to treat the absence, it's not going to protect you from the bigger seizures. And then as far as the other list, these were the drugs available when we did the study, so that's why I kind of listed them here, and I'll talk about some newer ones later. But Depakote is the drug that is commonly used, and it was the first broad spectrum out, so all the old literature in Angelman for seizures talks about Depakote and Klonopin, which is one of the benzos, transines, and also the older benzo, which isn't really used anymore, but there's some people that were put on it 30 years ago and just never came off. So so between the older benzos like Klonopin and transine and the Depakote, those are the ones that were used in the 70s and 80s and early 90s, because that's really all there was. And then the newer ones started coming out in the mid-90s. So Fablotal we don't use that much because it can have some pretty nasty side effects. But then these are the ones that are used: Lamictal, Zonegran, Topamax, and Keppra. And I can talk about those later. But these are all good broad-spectrum drugs that will treat absence, will treat tonic, will treat atonic, will treat tonic-clonic. So those are kind of the ones to focus on. And then as far as, so this is just from the study again, just kind of shows that this was Depakote and this was Klonopin. So when we did this study, they were still by far the most prescribed drugs. I think if we redid this study now, we'd see a lot more Keppra, Lamictal, and some of the newer medicines. But that was really our main finding, was that, and you can see on this slide, the purple is people that became seizure-free, the red are the people that had seizure exacerbation. But you can see that Depakote and Klonopin are still helpful, but a drug like Keppra is just as helpful. This is Tegretol, so you can see how many people had worsening of seizures and how few actually were helped by it. But kind of the main thing we found with the drugs was that Keppra, Lamictal, the newer drugs, to a lesser degree Topamax, were just as good as Depakote and Klonopin for stopping seizures, but had fewer side effects. So that's kind of what we do, and I'll talk about that a little bit more. But these are the newer medications. So so I'll talk about each one. So clobazam isn't really new. It's been around for decades, and for years in Europe and in Canada, it's been a first-line medicine, and it's really a great medicine for seizures and Angelman syndrome. And I'll talk about that one in a little bit. But so this one came out in the U.S. in about 2011, maybe 2012. So not super long ago. But it was so good that we actually had a lot of families on it that we ordered it from a pharmacy in Canada, and it got shipped across the border, and they had to pay out of pocket. And for a while it was really expensive because there was a New York pharmacy that dispensed it, but that was like $2 a pill. Then finally we found a pharmacy in Vancouver that was much cheaper. But clobazam is really a great medicine. Then these next two aren't so new, but they were after the study. So Banzel or Affinamide came out in 2010. Vimpat or lacosamide came out in 2011, and I think I've had pretty good luck with these. So these are two medicines I feel comfortable using kids with Angelman syndrome. Rufinamide is a classic broad spectrum. Its indication is actually Lennox-Gastaut syndrome. So that's kind of the seizures we see in Angelman syndrome is pretty much what it was designed for. And we've seen pretty good luck with it. It doesn't we don't have to get a lot of, we don't have to draw routine blood work for it. You don't have to, there's not a lot of side effects like tremor with Depakote. Lacosamide wasn't kind of billed as a broad spectrum medicine, but it really is. The more we use it, the more it's pretty clear that it helps all types of seizures. So that's a drug that we're really using more and more of just in general. But I would also be very comfortable using it in Angelman syndrome. And the last three are new. So fatigue has been out for about a year, is dopamine. And we used it on a couple of kids early on, but then a warning came out that it can turn your skin blue, and they're not sure if that's reversible or not, so that kind of scared us off. And what's really scary is it can turn your retinas blue, so luckily the couple of kids I had on it didn't turn blue, so we got them off it, and I haven't used it since. I would be careful with that one. Perampanel is really new. That's only been out for about a month, but it's very promising. It's what it does is there's no other drug like it. It's what they call an AMPA receptor blocker. So unlike the like the clobazams and the benzos, they try to kind of enhance the drugs that quiet things down, whereas what perampanel does is it tries to block the transmitters that speed things up. And the side effects are supposed to be similar to Keppra. Sometimes you can potentially get cranky, irritable, but not that big a proportion get that. And there's really no scary side effects that come with it. So that's one that we're really kind of interested in and excited about. And I think that's one worth trying. If the kind of standard ones haven't tried yet, we're going to start trying that on kids that have failed a bunch of other medicines. So that's one that I'm excited about. The last one, eslicarbazepine, I think the jury's out on that one. So you can see the carbazepine in it. So it's kind of a newer generation relative of Tegretol and trileptal, which you can see are on the bad list. So I would be careful, but they're billing this as a broad spectrum and saying that it actually will be good for all seizure types and not just the. So I'm not giving hope on it. I wouldn't use it in kids with Angelman yet, but as it's being used more and as data is gathered and as people gain experience, that might be a medicine down the line that is helpful. But I'd be a little careful to start off just because being in the Tegretol trileptal family, I'd be a little bit worried just because we know those two drugs really make things worse in Angelman syndrome. And then this one I'm sure there's going to be questions about. So cannabidiol, so with cannabidiol or CBD, the abbreviation, it's part of the marijuana plant. So with marijuana you have two parts. You have the THC and you have the cannabidiol. And the THC is what makes it famous. That's kind of what gives you the psychoactive effects, pretty much just what gets you high. Whereas the cannabidiol doesn't, and that's the part that we think can be helpful with seizures. And there's it's such a huge topic right now everywhere. But the bottom line is that it really has never been in trials, and we don't have any data on it. There was a piece on CNN where one girl got better, and so now so many people just want their kids on it, and we've had families move to Colorado. But that's that's really a scary proposition because what if that was the exception to the rule and most kids don't get better on it? So it's very promising, and there's anecdotal evidence, and so we're excited to see what it does, and it could be fantastic, but it could also not be fantastic, and we just don't know yet. So there's a trial going on now, and we're actually looking at 5 sites. There's 5 sites, 25 kids per site. We're starting to enroll now, but we're close to enrollment. But we're starting the trial. But within the year, we'll have a good idea of how well it works, and if it's not really working well for most kids, then it's probably not going to go any further than just that trial and kind of all the extent for nothing. But if we see really good results, that's kind of, at that point, that's when the drug company takes the data, goes to the FDA, and we try to get it approved more universally. But so the bottom line really is that it's very promising, but there's absolutely no data on it and just a few anecdotal cases. So while there is excitement and it's promising, we just don't know. We don't know yet if it's going to be helpful. And so the trial is going to go a long way. It's the first ever trial with it anywhere in the world. So we're really excited to see kind of what that looks like. And then so this slide is exactly as I described. It's my favorite. So there's no scientific data, there's no publication, this is just what I like. And so my 3 favorite medicines are, for kids with Angelman, are Onfi, Keppra, and Lamictal. And I know I keep saying kids, but kids and adults, but I call everybody my kids even if they're 40. So So Onfi, Keppler-Lemaitre. So Onfi is probably my favorite overall because not only is it great for seizures, but it we often see sleep and sometimes anxiety get better as well. I have some adults in their 20s, 30s that are on Onfi, and it really helps with their anxiety, and that's kind of mainly why they're on it. And again, Keppler-Lemaitre, like we saw in the study, just as good as the older medicines, but much fewer side effects, no routine blood work. So that's all great. And the reason sorry, I'm skipping around a little bit. The reason Onfi works so well, I think, is because it's so all the benzos, the Onfis, the Klonopins, the Ativans, they all work on GABA, and those are the receptors that are missing or just not functioning right in Angelman. So it really seems like people with Angelman syndrome really just do super well on these benzo type medicines. So, and obviously really the only one that's kind of meant to be an everyday medicine. Klonopin and Transine can be, but they tend to have a lot of side effects and wear off after a while. So I'm usually the one. So that's kind of the one I use the most. And then ones that are also that we definitely use and are helpful are the Topamax, Zonegran, the Depakote, Zerontin, Klonopin, Banzylvimpat. So the other kind of broad spectrums. And then the ones that I think are promising are Fycompa and the cannabidiol. One just came out and one's still in trials, so we don't know yet, but they both seem promising. And the ones I'd be careful with, Potiga, just because we don't want kids turning blue, and the Aptium, I think we just really need to wait and see how it works with generalized seizures before we start getting kids with Angelman syndrome, knowing how they respond to Tegretol and Trileptal. And then almost done. So as far as treatment of non-convulsive status, again, I should probably put my favorite at the top. There's nothing really published on this at all, but what I find super effective is a 6-day tapering course of Valium or Ativan. So again, the benzos, they work amazing in kids with Angelman syndrome. So typically, if I see that EEG that we saw before on that kid in non-convulsive status, and the whole story, losing skills, losing milestones, the whole bit, only once have we actually admitted someone to the hospital, and that's because they waited so long that they'd kind of stopped eating and drinking, kind of had no choice but to admit it and be more aggressive. But every other kid that we've had go into status, we've treated as an outpatient. We send them home, Valium, Ativan. Typically, with the first 6 days, they get about 80% better. We do another 6 days, and that usually wipes it out. And then we repeat the EEG, and it's usually back to the way it was. So if you catch it, if you recognize it early, treat it early, you can really even avoid a hospitalization. So it's really important to kind of keep an eye out for it and to treat it aggressively if possible. And the other thing to do is treat the underlying cause. There's often something that triggered it, whether it's poor sleep, you go away on vacation, they sleep 1 hour a night for a week, they come back and they are, losing milestones. It's because they didn't sleep for a week. Nasty infections, combination of infection and poor sleep. Those are all things that can tip a kid over into non-convulsive status. So treating the underlying cause, getting them to sleep better. And if they go on Valium, they're going to sleep better because it just that's what it does. And so it's kind of treating what's maybe underneath everything that's going on. And so moving on to dietary therapies. So those are the drugs we use. There's 2 different diets we use: ketogenic and low-glycemic. The classic ketogenic diet's been around since the 20s, but there's evidence of going back to the ancient Greeks. What they used to do hundreds of years ago is they used to starve people with seizures and they would stop seizing. But that's not really an option for us these days. So what they did was 100 years ago they developed a diet that kind of makes the body think it's starving. So when we starve, instead of eating sugar, we just burn the fat that we have stored in our bodies. So it's a diet that's just meant for the brain to just burn fat instead of sugar. So it's a high-fat diet, about 90% fat, that allows for only 10 grams or less of carbohydrates per day, which is just a tiny, tiny amount. We go as far as to use low-carb toothpaste, and to only use pills instead of liquid meds just to get every gram of carbohydrates out of the diet. And the typical ratio is 4 to 1, so 4 fat and protein calories to 1 carb. But it can be less. You can do it 3 to 1 and 2 to 1. So there's a little bit less fat in the diet. Until we admit kids to the hospital for usually 48 hours. In the old days, they used to fast, so no eating anything for 24 hours. We don't do that anymore. We just start the diet, so there's no fasting involved. And then really close lab monitoring. We usually check labs a couple times a day for the first couple days. Then at 1 week, 2 weeks. And you need to monitor for ketosis, acidosis. So really, when you're on the full ketogenic diet and you have all those fats in your system, they're actually fatty acids, so your acid-base balance gets really thrown off. And if you're on a medicine like Topamax or Zonegran, that's going to worsen it. So we usually give a buffer called polycitra, and that kind of helps to buffer that. But if you really get acidotic, it's going to worsen your seizures. So sometimes it's a bumpy ride in the beginning as the body adjusts, but usually once the kids settle in, we see really nice results. And this is easier to do for kids with G-tubes because there's a ketogenic formula, but you can certainly do it without a G-tube as well. And then typically you see cholesterol go up to hyperlipidemia, so increased cholesterol, triglycerides. But typically there's a big spike in the beginning and that kind of slowly drifts back down. And especially if you're doing it in kids, their hearts are so healthy that they can stand several months of higher lipids. But it can also cause decreased bone density, so we always supplement with vitamin D and calcium and a multivitamin. And some kids also, their carnitines will go down because carnitine is what kind of sends fats across the mitochondrial membrane into the mitochondria to burn them. And so carnitine levels often go down too, so we monitor those and we supplement that as well. And then, so based on that, actually was developed here with Elizabeth Teal, who I work with, and Heidi, our dietitian, the low glycemic index treatment. So it's an easier version of keto. With keto, you're actually burning fat, and you got all these fatty acids floating around your system. But with low glycemic, what it does is, with keto, you also, besides just burning fat, you have low stable blood sugars, and you have low stable insulin levels. So low glycemic kind of takes that piece out of keto and just uses that. So so most kids don't become ketotic on low glycemic. You know, it allows for 40 to 60 grams of carbs per day, so a lot more carbohydrates. But there are carbohydrates that don't raise your blood sugar much, so it's not 40 grams of donut. It's more like 40 grams of a low-carb pita, or of sometimes brown rice, but we kind of avoid that too. But just basically carbs that just don't increase your blood sugar. And so it's 10% carbs as opposed to a couple percent in keto, about 20 to 30% protein, and only 60 to 70% fat as opposed to 90% fat. So what's nice about it is that we don't admit for this. The monitoring is less strict but still needed, and then the meals are based upon the percentage of calories plus however many calories you need. Compliance is better because ketogenic because it's less restrictive. In general, what we see is about a third of people don't respond, or they just don't tolerate it well. About a third we see a 50 to 90% reduction in seizures. This is in the general epilepsy population. And then about a third we'll see a 90% or more reduction in seizures. And with low glycemic, it takes a little bit longer. It can be within the first couple of weeks, but it can also take a couple of months to really kick in. And then so one more note on the LGIT, that's kind of a partial list of our labs. So CBC electrolytes, liver function, renal function, pancreatic functions, carnitine, urinalysis, urine creatinine and calcium, calc-mag, phos, thyroid hormones, vitamin Ds. So kind of the take-home point to this, we check that at a baseline on a month and then every 3 months. And I can't really emphasize enough, do not do this by yourselves. You really need a dietitian and a doctor following, because if it's not done exactly right, if you become acidotic, you can get real sick, and you can really off the seizures. If kids that try to do this sometimes by themselves, well, not the kids, but families that do it by themselves, we've had kids come in who've been seizing like crazy because families tried it before they met us, and they're really acidotic. Your calcium can drop, your vitamin D can drop. You can really get into trouble if things aren't being monitored. And even if you do it right, I mean, if you do it too well, if you do it so well that you're almost more doing ketogenic, then you can really become acidotic, and so you really have to be careful. You really want to make sure it's done. And people can come to Boston, but there's also there's a website, the Charlie Foundation, and I can make sure Sheila has that. But it's actually started by the guy who made the movies Airplane and Naked Gun and all those kind of awesome movies from the old days. But his son had epilepsy, his son Charlie, and so. And they looked for years and nobody ever offered them diet therapy. Eventually went on keto, became seizure free. So that's kind of his mission now. So the Charlie Foundation is run by him in honor of his son, and Heidi, our dietitian, is on the board. But they have a great website where if you just type in where you're from, they'll tell you what the closest diet centers are. So there's diet centers all over the country. So even if you can't make it to Boston, there's places all over the country where you can get help with these. And then so we did a trial a few years back. We published it in 2012. But we put 6 kids with Angelman Syndrome, all with deletions, on the diet, and 4 of the 6 had more than 90% seizure freedom, with 2 actually seizure free. The other one in the 50 to 90 range, but that's actually about 80%. So 5 of the 6 had 80% or more seizure reduction, and then one was less than 50%, but they stayed on the diet, and at about 1 year, were also 90% seizure-free. So we really had good luck with those kids, and since then we've placed about 15 kids total on the low-glycemic with Angelman syndrome, and have really had good results with everybody. So what we don't know is if it's that really something about the biology of Angelman syndrome is more susceptible to having diet therapy work, or if it's just that the parents are all so good that they just do it really well. It's probably a combination of the two, but we've had good luck so far. And the last thing is the vagal nerve stimulator. I won't get into a lot of detail, but I don't think we have anyone. We maybe have 1 or 2 kids with Angelman who have this, but this is when diet and medicines fail. But really we don't get that far because diet usually works if the medicines fail. So, but it's a device that goes in the chest and it gives off a little signal up the vagal nerve into the brain. And what we see is it's about half the people have about a 50% reduction in seizure. So in some people it works great, and some people it doesn't work at all. And it's never curative, but if you're having 50 seizures a day and it gets you down to 20, it can be helpful. But fortunately, we really haven't had to go that route. We've had enough luck with medicine and diet that we haven't had to go there. But that's the only real surgical option, because what we call resective surgery, cutting the part of the brain that's seizing out, isn't really an option in Angelman syndrome because the gene is defective in every brain cell. So there's not just one part of the brain that you can really target. And I think that was it. This is our group, and I know it's getting a little bit, but I can stand a little bit past 1 if needed for questions.